Well, good afternoon, everyone. Can you all hear me?
Yes, I can
Ye-
hear you great.
Yes.
Okay, great. My name is Dr. Stephen Adams. I'm medical director for APO Community Health Center. Um, the reason I'm presenting this today is I've been doing LGBTQ healthcare since 1995, when I began doing HIV care as a faculty member for our local family medicine program. I was faculty there for about 5 years, and then I became medical director for urgent care. And for the past 17 years, I've been medical director, in addition to my medical director at urgent care, I've been medical director at APO. When I first started there, we only did care for folks living with HIV, but I took care of folks who were trans, bisexual, as well as MSM. Um, about 10 years ago, with the push for increasing the amount of PrEP that was out in the world, we started opening our doors to folks not living with HIV. And so we increased our population of folks getting PrEP as well as our transgender population. Today, we take care of about 700 patients, or about 2,000 patients. We have about 700 living with HIV. I have about 400 transgender patients, and I have about 400 primary care patients who are also on PrEP. So I'd like this to be mostly kind of a conversation. If people have questions, just interrupt me. You can come off mute. You can type something in the chat. If you type it in the chat, I may not see it right away, but Trish says she'll nudge me if I don't see something. So let's get started. LGBTQ healthcare. And for those of you, there are a few of you, I recognize your names. You have rotated with me at APO, and you realize that all of this stuff is really not very scary. So what does all this stand for? Lesbian, gay, bisexual, transgender, questioning, and a host of other sexual orientations other than heterosexual. So anything that's not strictly heterosexual kind of falls into these categories. Additional terms to know, cisgender, that's someone who is presenting as the gender they were born, they were assigned at birth. Transgender is someone who is a gender not assigned at birth. Commonly used today are AFAB and AMAB, assigned female at birth, assigned male at birth. Tops and bottoms in an MSM relationship, the insertive partner is the top. The bottom is the receptive partner. Top and bottom in transgender patients also refers to chest anatomy and genital anatomy. MSM is the term that we use most commonly for gay men, men who have sex with men, because many men who have sex with men do not consider themselves to be gay. So what are our patient care goals? They're really not different from any of our other patients that we take care of. Our goal, whenever a patient comes in, is to identify and manage that patient's health risks. And there are some differences in sexual health risks depending on who you're having sex with. And in our transgender population, it's no different than caring for a cisgender patient who needs hormone replacement, with the caveat that some of their body parts are different than a cisgender patient, and we have to be mindful of that as we care for them in the long haul. So how do we identify risks in patients? We ask about family history. We ask about the patient's own medical history. We look at their vital signs, their lab results, lipid results, kidney results, liver enzymes. And we also need to know about sexual practices, because sexual practices do add additional risk to people's lives. And we have to be comfortable asking people about what their sexual practices are and how that impacts their risk, and how do we modify that risk based on those answers. So if you're asking about sexual practices, don't ask, are you having sex with men or women? Don't ask how many sexual partners in the past year. the way we do this in our practice, do you have one partner or more than one? If you ask how many in the past year, that can be a little shaming for people. If you ask if they have one or more than one, all we need to know is it's more than one, because that puts them at additional risk. We don't need to know a number it's more than one. Do your sexual partners have penises, vaginas, or do you not care? Especially when working in because we have a large transgender population, a lot of my transgender females or males will be having sex with a transgender female who happens to have a penis, which is different than having sex with a female who's a cisgender female. So you have to know what kinds of body parts are present when people are having sex, if they're having receptive vaginal or rectal intercourse, and are they sharing sex toys or fingers? Because all of those things change the risk based on those practices. So lesbians, they actually have the least amount of risk. If they have a stable relationship, one partner, they have normal pap smears, they don't need repeat pap smears. That's very similar to folks who are in a monogamous heterosexual relationship. If they aren't changing partners and she's had multiple normal pap smears, you really don't have to repeat those, because it's about your risk of contracting HPV. Multiple partners, sharing sex toys, especially with multiple partners, increased risk of HPV and STIs. And there's no change in the mammogram screening. MSM, same thing. You're in a stable relationship, you have one partner, a normal anal pap times 2 or 3 years, they have no additional risk. If they have more than one partner, you need routine STI screening. We do that every 3 months. We also recommend, if they have multiple partners, that those folks are on PrEP, and we also offer DoxyPEP, which we'll get to a little bit later. Routine STI screening in an MSM population is you're testing for syphilis, HIV, 3-site gonorrhea and chlamydia. That's oral, rectal, and genital. And yearly we check Hep C. In MSMs, you're also going to check an anal pap smear annually if they are at increased risk. MSMs have a 40 times increased risk of anal cancer due to HPV over the general population. So it's very important that we determine whether or not they have been infected with HPV. HPV vaccination currently is recommended for everyone up to the age of 26, and it is approved by the FDA up to age 45 in high-risk groups, and MSMs would be considered a high-risk group. And all MSMs should be immune to hepatitis A and hepatitis B. The hepatitis B recommendation applies to all people. That was a CDC recommendation last year. That all adults should be retested and revaccinated if they aren't immune to hepatitis B. And MSMs are at increased risk of getting hepatitis A, so they should be tested for and immunized if they are not immune to hepatitis A. Screening for other groups, screening for STIs and doing PAPs is based on the type of sexual activities and body parts used for sex. In transgender men who haven't had gender-affirming surgery, who still have a cervix, but they don't participate in receptive vaginal sex, their risk of having an abnormal pap smear goes down to near zero. So you're going to need to ask those kinds of questions to determine what kinds of preventive measures you're going to have to do in order to keep people at low risk. So let's talk about PrEP. So anybody who's at risk, and really it's about having sex with people who have penises. If you're having sex with people who don't have penises, unless you're having sex with multiple partners and sharing sex toys, your risk of STIs and HPV is actually very low. But when you put penises in the mix, the risk goes up. So MSMs, AFAB or AMAB, having sex with men or sharing sex toys. What are our meds that we have available? 2 oral meds at this time. We have Truvada and Descovy. Truvada is now generic. It's going to be the preferred oral medication for all folks. Descovy is, we at this time, we don't have data on using Descovy in people who are assigned female at birth. So Descovy is only approved for use in people assigned male at birth. Apretude, which is injectable cabotegravir. It's an integrase inhibitor, long acting. You get those injections. The first 2 are a month apart. All the rest are every 2 months. We expect this year or early next year that there'll be a new formulation that will be every 4 months. And then next year, we're going to have injectable lenacapavir. It's a new class of medication. It's a capsid inhibitor. This is 2 sub-Q injections given every 6 months. The studies for lenacapavir just came out at the end of last year, and it was remarkably superior to oral meds. And in the group that was studying only AFAB, people assigned female at birth, there actually were 0 cases of HIV in that group in people who got their injections on time. So very, very effective medications. STI testing is every 3 months for our oral meds. And we're doing all the STI testing for anyone who's on PrEP. They all get 3-site GC gonorrhea and chlamydia. HIV, you must do an HIV RNA test. The guidelines also recommend that you do an HIV antibody antigen test that you send to the lab and then verify that with an HIV RNA test. In our clinic, we do the HIV RNA, we do all their testing a couple of weeks before they come in for their visit. And so we have their HIV RNA test at the time they come in, and we just renew their meds, and we don't bother with the antibody antigen test. Get a syphilis test with everything. And anytime a patient comes in with symptoms of an STI, no matter what that STI is, you should repeat all of their STI testing, especially their HIV test. How often are we going to test with injections? With Apretude, giving the injection every 2 months. We're doing every 4 months STI testing. Every time they get an injection, they get an HIV RNA test. I'm not quite sure what they're going to come down on with testing for lenacapavir, but because it's every 6 months, I would suspect we're going to do STI testing every 3 months. So Truvada you can use for any patient. Descovy is only for those who are assigned male at birth. We also know that in people assigned male at birth, Truvada is far more effective than it is in people assigned female at birth. If you were assigned male at birth and you take 4 doses of Truvada a week, it works just the same as taking it 7 days a week. And so there is an indication for using Truvada on an intermittent basis or episode induced basis. So if you're not very sexually active, you only have sex once a month, once every couple of months, you can take 2 tablets of Truvada 2 to 24 hours before you have sex, take a tablet 24 hours later, 48 hours later, and it's nearly as effective as taking it every day. If you're gonna go on a trip and you're gonna be sexually active for a week, you're gonna take 2 to 24 hours before. You're gonna take it every day until you've taken it for 48 hours after the last time you had risky sex. Unfortunately, the guidelines have been removed from the CDC website, but there are multiple other resources, including hiv.gov. All the guidelines are still there. DoxyPEP. This was a great study that came out early last year. They did 2 studies looking at effectiveness of using doxycycline, 200 milligrams, 24 to 72 hours after unprotected sex, and how is that going to decrease your risk of gonorrhea, chlamydia, and syphilis? Well, the decrease in risk is 60 to 70%, depending on the study that you read. But Unfortunately, it only showed efficacy in people assigned male at birth because there was very poor compliance among people assigned female at birth. So currently, there is no recommendation for using it in people assigned female at birth, though in our clinic, if you're on PrEP and you were assigned female at birth, we are offering doxycycline because it may be effective. For folks who are really sexually active, and they're taking it multiple times a week, you can take doxycycline 100 milligrams a day. We have some preliminary results. The study on that will be coming out later this year. And there are multiple other resources available, but not on the CDC website, which is where most of these guidelines were until just a few months ago. So transgender care. As I said before, this is really no different than caring for a cisgendered patient who is no longer making the hormones that they're supposed to make. So in our male to female patients, the only thing that's different is that we also want to suppress their testosterone, either their testosterone production or the action of testosterone. If we want to stop testosterone production, we're going to use spironolactone. Our starting dose is 100 milligrams a day. I usually have patients start at a half a tablet for 4 to 6 days because it can lower blood pressure, just to make sure they tolerate it, then go up to 100 milligrams daily. You can go to 200. The max dose really is 400. You don't get that much more benefit once you go above 200, but the max dose is up to 400 milligrams. Finasteride only blocks the action of testosterone. You're going to use a dose of 5 milligrams daily, which is the dose that we use in folks who have testicular cancer, and we want to block the action of testosterone. When you measure testosterone in those folks, those testosterone levels will be in the low normal range. In folks who are taking spironolactone, they're going to be very, very low in folks who are on high doses of spironolactone. Feminization, we're going to use the same medicines we would use in a cisgendered woman who had her ovaries removed for whatever reason and still needed estradiol to be around. We're going to start with a 4 milligram dose. For our transgender patients, we recommend that they dissolve those in their mouth. That avoids that first pass effect, and so they get higher initial blood levels, and they get better feminization. And we can use lower doses of estradiol. I have folks who are on up to 8 to 10 milligrams a day. Once you get above 4 milligrams, we recommend that you give it in divided doses because estradiol can cause some increased nausea. There is injectable estradiol as valerate or cypionate. The difference between the two is the kind of oil that's used. Some people are allergic to cypionate and you have to use valerate. There's no difference in the action. There's no difference in the dosing. Injections are usually given weekly. Unfortunately, currently, there is a nationwide shortage of both estradiol compounds. And so it's much easier for patients to be treated with oral tablets. If you go online and you're looking at trans female literature, there's a whole bunch of information out there about using progesterone to improve breast growth, to improve body fat distribution. The studies don't show that it's very effective, but it can make people feel a lot better about themselves. And so if people want it, I offer it to them. If they feel that it's made them better, then we keep them on it. If they don't notice any difference, then we take them off. So once you start transgender hormones in a male to female person, the permanent changes are breast growth. Once you start growing breasts, if you stop taking your estradiol, the breasts you have are the breasts you're going to have forever. Reversible changes, testicles shrink, fewer and less firm erections, hair growth slows, hair's finer, softening of skin, body fat redistribution, and decreased ejaculate. All of those things are reversible when you stop hormones. The real end point for any transgender patient is not a number. Our goal is to get someone to a place where they feel comfortable. And for some folks, that means we're going to be using much lower doses, so they feel just a little bit more feminine, or they feel more non-binary. And so the endpoint is not a number. The endpoint is the patient's reaching the patient's goals. So monitoring, once their hormone levels are at goal, we follow every 3 months for a year. And then anytime a change is made to dosing, we'll follow up in 3 months to make sure that we're getting to where the patient is therapeutic, but not dosed too high. Goal hormone levels or whatever the patient is most comfortable with, as long as it's within normal range for cisgendered patients. So when you get your lab results back, if the patient's gender marker has not been changed, all of those results are going to be abnormal because they're going to be results for their gender assigned at birth. So you're going to have to remember what the normals are for transgender patients or for cisgender patients so that you know that the patient is in a safe therapeutic range. For injectable meds, we measure the nadir. So we want that 1 or 2 days prior to their next injection. Some do midweek, so right in the middle. So they're looking kind of halfway in between. Testosterone injections at nadir, we're looking for a goal of 500 to 700 nanograms per deciliter. Estradiol injections, we want that nadir for injectable meds at 120 to 140. Testosterone, you really don't want them to reach levels above 1,000. And estradiol, you don't want them to reach levels above 200. Keep below 200. Topical testosterone, because they're doing that every day, it's going to be more consistent dosing. And so you're going to be looking for levels that are about 700 to 900. And oral estradiol, because it's every day, you're looking at higher drug levels when you measure them. So about 150 to 180 picograms per milliliter.
Dr. Adams?
Yes.
Can I ask what the risks are if they are above those ranges that you mentioned they should not exceed beyond?
So in folks who are on testosterone, we know that increases your risk of being angry. It also increases your risk of heart disease, including cardiomyopathy. So in folks who abuse testosterone, bodybuilders, those are their 2 biggest risks. In estradiol, the higher the blood levels get, the higher the risk of blood clots.
Got it. Thanks.
Transgender care monitoring, male to female need mammograms at age 40 or 10 years after their breast development. That once you start, then you follow the guidelines for cisgendered women. So if someone starts their medical transition at age 40 or 50, you're not automatically going to start doing their mammograms right away because they fall into the correct group. You're going to wait until they've had breasts for about 10 years. Then you're going to start doing mammograms. If they start much younger, then you're going to start at age 40. Male to female, you need to consider whether or not you're going to do prostate cancer screening, especially if they come from a high-risk group with a lot of prostate cancer in their family history. In male to female transgender folks, we monitor both estradiol and testosterone. Once they're stable, I usually just monitor their estradiol a couple times a year and their testosterone once a year, just to make sure their levels are where we want them. Female to male, if they have a uterus, and they're having sex with someone who has a penis, they need birth control. Just being on testosterone and suppressing estradiol production does not stop them from ovulating, and they are at risk of getting pregnant. So we recommend a long-acting reversible contraceptive. Most of our patients, I prefer to do IUDs without either with or without hormones, just because we don't want the hormones interfering with their masculinization. They're going to still get mammograms. It's per the guidelines based on their age, if their breasts are still present. Pap smears are per guidelines. Because we're turning off their estradiol, if we do a pap smear, all we're going to get back is a postmenopausal pap smear. It's going to show atrophy and not much else. So in order to get a accurate pap smear, we use intravaginal estradiol for 2 weeks prior to the pap. And that's for multiple reasons. That makes the lining of the cervix and the outer part of the cervix more normal for someone who is not postmenopausal. And it also makes doing the pap smear less painful because the vagina has more lubrication and it's less atrophic.
Dr. Adams,
Yes.
Is there recommendations for doing mammograms on male to female because of estrogen use?
Yes, they're going to start either at age 40 if they started transition before age 30, or they're going to start at 10 years after they start hormones. So what are our additional considerations? Medical transition is second puberty. It's going to happen all over again. The emotional stuff for female to male, the acne, which can be really horrible. But your brain on estradiol is not the same as your brain on testosterone and vice versa. And so patients are going to need support as they go through that process again. They're going to need support from their family, from their friends, and from other trans patients who have done this before. We recommend that they have a behavioral health counselor available to them as they're going through this process. Not everyone needs that, but it's nice to have already established a relationship with someone. They may need psychiatric care. I have a lot of transgender patients who have very serious mental health issues. People with borderline personality disorder, people who are bipolar that's poorly controlled, folks who are on the spectrum, and trying to determine what their true goals are and what they truly want out of hormone therapy may require that patient to see a therapist for a few months prior to starting their medical transition. And so it's uncommon. Most of the time, the patients come in, they give you the same story. You hear the same thing from all the patients who come in. I felt this way my entire life. When I hit puberty, it just got a whole lot worse because when I looked in the mirror, the person that was there was not the person I am inside my head. And I've been much happier since I've been living as male or female, opposite gender, and have been going by my other name, my chosen name, and everything is just better in my life. That's the story that's common. And when you don't quite get that from folks, then that's when you're going to ask them to get some behavioral health counseling and potentially some psychiatric care and get notes from those folks saying, yeah, I agree. I think this patient really is going to be better if they get hormones. You're also going to do routine preventive services and screenings as other folks with the above exceptions. Because people are going to have different body parts. So for transgender females, you're not going to be doing pap smears on them because they don't have cervixes. So you have to rearrange all your screening services based on what are the body parts that are there and how am I going to best take care of those patients. So for transgender patients, WPATH is the World Organization for Transgender Healthcare. Their guidelines are available online. The two other in the United States that have very large transgender populations and have published transgender guidelines are UCSF, which is in San Francisco, obviously, and Fenway Healthcare, which is in Boston. Both of them have put out guidelines that are very, very similar to the WPATH guidelines. These are where you can get those guidelines. I also included the triple site testing article and some guidelines on prescribing PrEP. And I finished earlier than I anticipated. Do you guys have questions?
I have a question. I am a third year and I'm on my rotations right now in Springfield. And I have unfortunately had to listen to quite a few doctors make comments about how if they have a non-binary patient or a transgender patient, they make sure to go in there and refer to their appropriate gender that they were born with and to remind them that that's what they were born with, etc. I'm going to be reviewed by these doctors. I would love to be more outspoken or opinionated about it because that's the type of person that I am, about trying to respect these patients. But do you have any guidance for how I could respond to those that does not seem to be inflammatory or opinionated and make them think differently about how they approach these patients so they do feel the respect that they deserve, especially from a medical care provider that is supposed to be taking into consideration their total health, which includes their mental health?
So I think that's a really great question that has a very complex answer. And I think, unfortunately, in our current environment, those physicians have been given permission to say those things and feel justified in speaking out in the ways that they're speaking out. And I think that you trying to intervene in that is probably just going to be detrimental to you. I think if you have an opportunity to, and you know that that's going to happen to a patient, and you have an opportunity to speak with a patient by yourself, letting them know that there are places in town where that's not going to happen, it would be a reasonable thing to pass on to the patient. I hear those stories almost every day with new patients who are coming in, that the reason they're coming to APO for care is because that was the experience they had with their prior primary care doctor or a specialist or someone like that. So I think because you're a student, the best thing that you can do is learn from those experiences about what's really bad and that you don't want to do in the future, and make a choice to really educate yourself on how to do it in a much better way.
Great. Do you have any resources that you could perhaps tell me or email to me, specifically doctors that are safe for patients to contact that would be less judgmental in the Southwest Missouri area?
Well, FMCC, the residency program, they have a transgender program. There is a doctor at Jordan Valley who is quietly doing transgender care. Dr. Mickey, last name starts with a B. It's Michaela. But she's doing a little bit of HIV care, some PrEP, and some transgender care. she's trying to remain under the radar. And then obviously at APO. Those are probably for OBGYN care, for our trans male patients, we send them to Physicians for Women. Those doctors are very happy to take care of our trans males who need hysterectomies or have other gynecological issues. And then the other big resources are KU, which has a large gender affirming program, and Washington University in St. Louis, which also has a large gender affirming program.
Great.
And those are the places that we send folks for gender affirming surgeries.
Okay,
'Cause
thank
we can't
you.
get that done here.
Well, kind of a related question to what Zenobia was saying. Just in your experience as a doctor, how have you seen as a whole, like other outside clinics treat the LGBT plus community as a whole, like the patients and whatnot?
It depends on the specialty. Not to be disparaging to Mercy, but we have way fewer positive encounters at Mercy than we do at Cox. I have resources in the GI department, the colorectal surgery department, which we use very frequently. And my patients who go to Cox get treated in a much better way than they do if I'm sending them to Mercy. Not universally, but that's mostly for most encounters. Overall, I think most LGBTQ folks probably don't tell their primary care doctors that they fall into that group, and their doctors never ask about their sexual practices, so they aren't going to know. And they kind of fly under the radar and really don't have those kinds of interactions. But when they do have to, out themselves for whatever reason, most of those interactions in primary care are not, I would say the vast majority are not good interactions. And that's very specific to Springfield, because we're in a very, very conservative part of the country. A lot of folks come here because they are very conservative and they feel comfortable in this community. And, so we don't get quite the diversity of providers that you're going to get in a larger city.
Do you think that also has to do with Mercy being a Catholic hospital?
Very much so.
Just if I can make a little plug on based off what you just said, Dr. Adams. I know it is a conservative area, but I, for example, plan on staying in Springfield and practicing here and taking care of all patients. And those patients that can't leave this area, transgender, gay, women that need abortions, whatever, if they can't leave, they still need doctors to take care of them. So I think the best way to try and balance out the conservatism in the area is to bring more liberal people here and take care of everybody as they should be.
Well, good for you. I've been here in Springfield since '95, doing exactly that.
I love it. I'm so glad you're here.
What other questions do you have?
Do you see any kiddos in your practice? And do you handle hormone replacement differently in kiddos versus adults?
It's illegal. It's a felony in Missouri to provide transgender care to anyone under the age of 18. So we do not have, I did, when that became illegal, I had a couple of 17-year-olds in our practice, and we don't do it any differently. For kids who are prepubertal, I would not take care of those kids. I would send them to the Children's Hospital in Kansas City, they had a large gender affirming program for younger children. That was a whole team of people. So we would send them there. I never had anyone that I sent there. Our youngest child is a 2.5-year-old who has HIV. My young kids are kids who are living with HIV. I have a 5-year-old, and an 11-year-old.
Dr. Adams, as far as STIs in the area, how do we stack amongst the rest of the nation? Is there any more like syphilis or anything here that we as practitioners will see in the future?
Well, in our patient population, we see a lot of syphilis. Our service area is about a quarter of the state. So just south of Kansas City to Rolla, down to West Plains. And we do not represent 25% of the population of Missouri, but we do represent 25% of all syphilis cases in the state. So syphilis here is much more prevalent than it is other places, including Kansas City and St. Louis on a population basis. And I believe that has to do with the conservative nature of our community, that we have a very large rural population who may not have access to good preventive care, especially if among the LGBTQ population.
Now, I know it's really early with doxypep, but do you presume or are you seeing instances of that trending down because of the use of doxypep?
National data does show that syphilis cases are down. Chlamydia is no longer a reportable disease because it's so prevalent. Gonorrhea cases, I saw an article on syphilis cases are coming down, and it was a pretty big drop, like 25% nationally. And I haven't seen anything on gonorrhea cases at this point. So for those of you who are interested in learning more about this, obviously we do rotations. Several of your classmates, Henry, Ivan, have been to APO. Ask them about the experience, what they'll learn, what you'll learn there. And we usually have 1 or 2 students at APO all the time. To get the experience of asking those sexual health questions, becoming comfortable with it, learning all of this stuff kind of hands-on. So come down and rotate, learn all you can.
I think I'll advocate for the rotation because it was a rotation where I think one of the best things I got out of it is being asked and to ask those uncomfortable questions with patients, which I don't think you get that kind of exposure anywhere else or any other physicians, which can really help with taking histories of like really occult things that might be related to sexual practices that we don't normally ask. But I think at APO, it was, encouraged to ask sexual history and questions like that, where in other places you might not get that. So it helps.
I would agree. I mean, I had a great experience at APO. It's a great, it helps you, I would say, a ton with like history gathering and feeling comfortable talking to patients. After that rotation, like there's nothing you feel like taboo or worried about asking a patient. You just feel much more comfortable being around and talking to people.
And you can see some really interesting stuff that you might not see anywhere else. Like Dr. Adams and I saw Kaposi, which is like extremely rare.
Well, thank you all for the great conversation, for the great questions. Um, Trish has my email address if people want to get in touch with me. Debbie in our office takes care of managing all the rotations. So if you're interested in rotating, even if it's for dropping in one day, you would be welcome. And thanks a bunch for letting me be able to present this information to all of you.
Thank you, Dr. Adams.
You're very welcome.